Let's talk about the shoulder joint on X-ray. When looking at any X-ray, follow this ABCS framework, meaning look for the adequacy if there's any rotation or any other views are available, the alignment of all the joints and bones, trace the cortex of each bone and look for any fractures, look at the cartilage or the joint spaces and the soft tissues. This is the 3D anatomy of the shoulder joint, and you can look at all the components: the head of humerus, the acromion, the clavicle and the coracoid. If you look at the head of humerus, the greater trochanter lies laterally and it forms a slight step with the rest of the head, and the lesser trochanter is lies in the frontal projection and it lies somewhere here. And if you look at the scapula, it is at an angle with the imaging plane, and that's why you cannot see the joint space clearly, and there's some overlap between the head of humerus and the glenoid, and this appearance is normal. If there is some external rotation of the arm, the greater trochanter moves further laterally and it forms a step with the head of humerus. If there is internal rotation, the greater trochanter comes anteriorly and the head acquires a more circular shape, and this is called as the light bulb appearance. Now these external and internal rotation views, we can utilize these views to, if we want to look at the joint space which is on the external rotation and this alignment of humeral head with the rest of scapula on internal rotation. If you externally rotate the patient and take an X-ray, you can see the glenohumeral joint space clearly, and this is called as the Grashey view, and it is used to mainly assess the glenohumeral joint space. If you internally rotate the patient, you get something called a Y view, where you can see the scapula forming a Y because of the spine of scapula. You can see the acromion and the coracoid, and in this view the head of humerus, it projects over the glenoid, and you can assess the relationship of these two in dislocations, whether the head is posteriorly or anteriorly dislocated. Now let's talk about the acromioclavicular joint. To assess the acromioclavicular joint, you should know about certain structures which support the joint. The first one is the acromioclavicular ligament, which reinforces the joint capsule. Then certain structures which arise from the coracoid process: the coracoclavicular ligament, coracoacromial and the coracohumeral ligament. To check for the alignment, you should compare the inferior surfaces of the clavicle and the acromion and the line joining the inferior surfaces. If there is any tear in the coracoclavicular or the coracoacromial ligament, there will be a step in the line joining the inferior surfaces, and this will suggest acromioclavicular separation. Also, the distance between the clavicle and the coracoid process, it should not exceed 13 millimeters. If it is more than this, it suggests the rupture of the coracoclavicular ligament. Now, if you look at all these structures, these form a narrow passage through which the muscle supraspinatus passes, and it attaches on the greater trochanter of the humerus. If there's any further abnormality of the AC joint or some overcrowding in the space, it can lead to impingement of this muscle and can cause degenerative tears. For example, if there's any AC joint degeneration, it causes hypertrophy of the joint, or if there's any inferior osteophytes along the clavicle or the acromion, it causes impingement on the tendon of supraspinatus and can cause tears. Now, what is os acromial? The acromion develops from multiple ossification centers which join by the age of 25. If any of these ossification centers fail to join the rest of the acromion, it is termed as basi, meta, meso or pre-acromion. An os needs to be differentiated from a fracture, and it's done by looking at the margins. If it is smooth and corticated, it's an os, and if it has non-corticated edges, it's more likely a fracture. On frontal views, you may not appreciate the os, and you need an axial view to accurately diagnose it. Now the acromion shape can also vary, and it has a few variants. If the inferior surface is completely straight, it's type 1, curved is type 2, if it is hooked, it's type 3, and convex is type 4. Now especially in type 3 variety where it is hooked, the chances of impingement is higher. Now the coracoid. The coracoid is a very important structure. As we saw earlier, many of the ligaments are attached to the coracoid, the coracoclavicular, the coracoacromial, and the coracohumeral ligaments. It also has three muscle attachments. The first one is the coracobrachialis muscle, which attaches to the medial surface of the humerus and the coracoid. Then the short head of biceps attaches to the coracoid, and the long head goes above the head of humerus through the bicipital groove and attaches at the superior aspect of the glenoid. And the third muscle which attaches to the coracoid is the pectoralis minor muscle. If the head of humerus has a subcoracoid location, it suggests an anterior dislocation of the humerus. Now let's look at the glenohumeral joint. First, we should look for the alignment of the glenohumeral joint, which is done by looking at something called the Maloney's line. First, we need to look at the alignment of the glenohumeral joint, and it is done by looking at the Maloney's line, which is a line passing along the inferior surface of the scapula, the glenoid, and along the shaft of humerus. If this line is disrupted, it suggests a dislocation. In anterior dislocation, the humerus moves inferiorly and medially and acquires more of a subcoracoid location like this. There's anterior dislocation of the shoulder joint with a subcoracoid position of the humerus. In posterior dislocation, there occurs some internal rotation which causes a more rounded look of the humeral head, and this is called as the light bulb appearance. Now let's go through the checklist again. Look for the adequacy. If there's any rotation or any other views available, look for the alignment of the glenohumeral joint and the acromioclavicular joint. Look at the cortex of all the bones to look for any fractures. Look for the cartilage spaces. If Grashey view is available, look at the glenohumeral joint space and look at the soft tissues around the joint.